The hope is that we can integrate some form of therapy that rely on, let's say, conversational agents to allow to shorten the duration of therapy from 15 to 10 or 8. We have to be innovative. We have to think a little bit outside the box. We have to rely on technology, artificial intelligence, large language models, to integrate technology in our clinical practice.
Hello, friends. Here we're again in a new episode of AI and Mental Health. Let's talk about it. Today we have an expert in youth mental health. It's Dr. Antonio Hardan, who is the Chief of Child Psychiatry at Stanford. Antonio, thank you so much for being here today.
Thank you, Eduardo. Thank you for the invitation to talk about the topic that we deal with on an everyday basis.
Okay, good. So this conversation, I hope that we can have like a big overview of the state of youth mental health in general. And I believe that this is something that should be relevant for parents, but also for mental health professionals working with youth, right? Why? Because I think that we should work together as a team. We're all in this together, and we need to understand each other's perspectives. So do you have any comments?
Very important in pediatric mental health, in contrast to working with adults, is that in pediatric mental health, we have the parents who are part of the team, and we have all to work together to lead to a better mental health state of the child.
I would add also the schools, right? Many times are a big part of the team that should be helping in the success of this child, right? So, Antonio, this is a question that may be more relevant for parents, but what are the main things about youth mental health that a parent should know?
We get questions on a regular basis from parents who are wondering about the state of the emotional well-being of their child. So, as we all know, children experience emotional disturbances up and down on a regular basis. They lose a basketball game or they get a bad grade. So it's expected, and that's part of life. What I tell parents is they have to be concerned when the emotional troubles, they last more than they would like them to be. And more importantly, when the emotional disturbances are affecting the functioning of the child, grades are dropping, they are not going out to interact with their friends, they are isolated in their rooms, teachers are reporting that the child is not paying attention or they are moody and irritable. So it's the duration and the severity that's affecting the functioning of the child.
Nice, thank you. And are there any specific things that we should kind of pay attention as parents, depending on the age of our children?
Definitely. A change in the behavior. If Mike is used to do ABC and now is not doing ABC, he's doing A and maybe B. So that's important, independently of the age. Now, for children, it's a little bit different than adolescents. Adolescents are more complicated because a lot of the behaviors, the adolescent behaviors, they are to some extent expected, and it's different than what we see with children. For example, with children, if we see that the kid is not interested in going out and playing with their peers, if they are not paying as much attention as before, if they become scared of dogs or scared of things that they usually like to interact with. So we see that very common in young kids. In adolescents, part of the behavior that they exhibit will make us worry quite a bit. For example, when they start isolating themselves, that's expected for adolescents. But if that's accompanied by not interacting with their peers, a drop in the grades, and significant sleep disturbances, that's when we will have to worry a little bit more about their behaviors.
Thank you. And going to the children first, in the first years of life, which are the main things that we should worry? Is it normal to see like a child that is 3 years old with depression or more anxiety or developmental disorders? What should we expect?
The onset of different disorders will depend on age. For example, depression is more commonly observed in adolescents compared to children. We do see it in children, but at a much less frequency than in adolescents. Disruptive behaviors, ADHD, externalizing behaviors, we usually see them a little bit more in young kids compared to adolescents. For example, the average age of onset of ADHD, or when it's first recognized, is around the age of 7, 8, and 9. So that's when we see most of the time parents calling our clinics for an evaluation of attention deficit hyperactivity disorder.
Thank you. And let's say that I have seen things in my child and I am concerned, right? And are all the treatments the same? Is it okay for me to get any treatment from a mental health professional?
Definitely not. Definitely not. There is what we call in the field evidence-based interventions. So, and we recommend for all the parents to inquire whether the therapy that they are receiving, whether it's evidence-based or not. We recommend that all children receiving treatment in the beginning to receive evidence-based. Evidence-based means there is significant scientific evidence, significant research supporting the efficacy of the specific intervention. Unfortunately, in this day and age, we have a lot of intervention that have been shown that are effective in the treatment of specific disorders in children and adolescents. For example, parent management training, PCIT. These are interventions that have been shown to be effective in the treatment of disruptive behaviors in young kids.
Thank you. Now, I had conversations with parents about this, and I've heard sometimes parents saying, well, but they've done an evidence-based intervention and my child was still doing poorly.
It's a challenging question, and we get that at times. We usually recommend, as I mentioned, that parents start with evidence-based intervention. So you start with what's been shown to be effective, and you would try that for a specific period of time. And if that intervention is not effective, then it's okay to try to see and to rely on intervention that have not been proven. But what we've seen in our clinical practice is sometimes parents start with non-evidence-based intervention before they switch to evidence-based intervention. So that's a little recommendation for the parents is if your child is diagnosed with ADHD, is your child diagnosed with anxiety or depression, to go and start with the intervention that have been shown in multiple research studies, but also in clinical practice to be effective.
Thank you. I think one important distinction is that when we say that they are effective, that doesn't mean that they are effective with all, right? There's no 100% guaranteed with, but there's more chances, at least we know that the treatment is safe, the harm benefit is kind of more in favor of the benefit, right? The relationship. But of course, we cannot help everyone, at least as of today, right?
Yeah. And there are several variables where some interventions are not effective with all the kids. One of them that is critical for psychotherapy is the relationship between the child and the therapist, and the relationship the child therapist with the parent. So it's different than taking a medication. So if a medication, usually if you're taking it, it should be theoretically effective up to 70, 80%. For psychotherapeutic intervention, if the relationship is not optimal between the child and the therapist, that's going to affect the outcome. So that's why it's not surprising that sometimes there is no chemistry between the family, the child, and the therapist. And it's definitely worth exploring, working with another therapist to see whether the evidence-based intervention will be more effective with another clinician.
Thank you. And another thing that I think is important to distinguish is that when we say effective, we don't mean that we revert completely every problem, right? It's like we're reducing some symptoms, correct?
Yeah, yeah. And that's something very important that the parents should discuss with the therapist. It's expectations. What is the expectation of the treatment? a common case scenario that comes to us with kids who are very shy, who have what we call like a social anxiety disorder. We have to be realistic that after the end of the treatment, the kid's not going to become a social butterfly. So setting this frame is very important. So the parents will know that at the end of the treatment for the case of the social anxiety disorder or shyness, the kid will become more comfortable in social environment. They might be able to raise their hand and answer a question during in class, or they might feel a little bit more comfortable engaging with another child, but it's not they're gonna go and then talk to five, six different people in a birthday party.
So basically you're saying you're improving the functioning, but you're not changing who that boy, who that child is, right?
Correct. Improving the functioning and optimizing social interactions.
Thank you. Now, in early childhood, we have internalizing disorders, anxiety, depression that you were mentioning a minute ago, and we have externalizing disorders such as disruptive behavior. What are the difference when I have a anxious child or a disruptive child when I go and seek therapy? How does the treatment work?
As you mentioned, in childhood onset psychiatric disorder, we divide the diagnosis or the disorders in two big categories: externalizing and internalizing. Externalizing are manifestations that are observed by the external world, by the parents, such as impulsivity, hyperactivity, distractibility, temper outburst. The internalizing disorders are manifestations that are not usually observed by the parents, by adults, that are more experienced internally, such as worries, dysphoria, suicidal ideation, nervousness. Now, with regard to the treatment, and parents should be aware of that. When it comes to internalizing disorder or internalizing aspects of psychiatric disorders, treatment should include a one-on-one with the therapist, with the parents being involved from time to time to provide feedback or to provide an update on the child. For example, if the kid is anxious, you would expect that most of the time the clinician will be spending time with the child and a little bit with the parents. In contrast to internalizing disorder, externalizing disorder, it's very important that the parents are involved in the treatment most of the time, where they learn skills on how to deal with their children. You could have a component where it's a one-on-one, where there is some involvement in uh, play therapy, but most of the work should be done with the parent, with the child either being present or sometimes not present.
Thank you. So a brief summary. So if someone has an anxious child, most of the treatment could happen with the child. But if someone has a disruptive child, most of the treatment should happen with the parents.
Correct.
Now, here I have a personal question. I have the sense that most therapists in the community and even in school settings, when they have disruptive children, they work with the child and not with the parents. Do you also see this?
Yeah, we see that very frequently in our clinics, and we very rapidly, very quickly will inform the parents that for disruptive behaviors, most of the work should be done with the parents. And the focus of that work in the parent management training or the other form of treatment, PCIT, is to teach parents skills so they will manage their kids' behavior.
Do you have any idea? This is absolutely like a guess, probably, why therapists working with children with disruptive behaviors tend to see more the children than the parents?
Yeah, it's very hard to explain that, but there is a belief in the psychiatric fields and among parents is that if the child is experiencing problems, you have to start talking to the child and provide psychotherapy with the child. It's probably true. It's definitely true for internalizing disorder, but for externalizing disorder, the evidence support that teaching mothers and fathers, parenting skills is key for improvement in the child's behavior.
Thank you. And let me make a distinction because I think that it's important. One thing is the diagnostic process, and the other thing is the treatment. For the diagnostic process, you will always see the child, you will also listen to the child and try to understand why those disruptive behaviors occur. If the diagnosis is more, hey, the child has oppositional defiant disorder, then the treatment is more with the parents.
Yeah, yeah. And depending also on the age of the child, when you're working with a patient with disruptive behavior, externalizing disorder, you want to involve a little bit the child, for example, in designing the behavioral plan, identifying the rewards, what the kid is interested in. And as you would expect, a 7, 8-year-old child, their involvement will be a little bit different than an adolescent. Usually, when we're talking with an adolescent, we would discuss with them what the rewards should be, and we want them to be engaged and involved in that decision because that's key in the success of the behavioral plan.
Thank you. Let me start by saying there are no universal rules in mental health, right? But which one would be your top one?
Yeah, that's a tough one because it's not only one. Like it's not fair.
I'll
So
give you three. I'll give you three.
okay, very good. So I would say like consistency, predictability, creating like a supportive and rewarding environment for the child. Like these are what comes to mind. I'm sure that I'm missing others, but right now that's what's important, especially for disruptive behavior. Being consistent that if you do this, that's going to be the positive consequence or this is going to be the negative consequence. So that's important. So the child knows it's predictable. The environment is predictable for them. The worst thing that can happen for the child is that if they do not comply, sometimes they will get a consequence and sometimes they not. That's going to drive them a little bit off the walls, and it's not important. It's very confusing to them. So that's why, in addition to that, is creating a positive, nurturing environment. Even though the kid might act out, they will get the consequence. But the overall environment, the background, should be a positive and rewarding and supporting environment.
Most treatments for disruptive behavior start by be sure that you have a good relationship with your child, because this will help them be more motivated to do whatever you want them to do, but also they'll have a better mood, right? And if I'm in a good mood and you ask me to do something, there's more chances that. So this is something that I think it's key, and it's not also only a benefit for the child. You as a parent, when this comes back, right, you feel better yourself.
Yeah, a very frequent recommendation we make to parents of kids with disruptive behaviors is to dedicate a specific time when they play with their kid, independently whether they had a bad day in school through a major tantrum, is to dedicate half an hour, 1 hour when they are working on the relationship with their child, because investment in a better relationship will lead to an overall better quality of family life.
Absolutely. Thank you so much, Antonio. I'd like to shift gears now and ask you questions more related to the problems that we're having today in mental health. So what would you say that are the biggest problems in youth mental health today?
That's a topic where we can spend a full day discussing. So, what comes to mind, like the biggest problem that we face, as a division chief, we run into that problem on a regular basis. One is access to care. That's an important challenge we're facing. The second is monitoring the quality of care. As I mentioned earlier, if you prescribe a medication, the quality of that medication is standard across the United States. But if you prescribe parent management training or individual psychotherapy, the quality of that intervention is going to depend on the therapist. And as you mentioned before, on the relationship between the therapist and the patient. So that's important. So monitoring fidelity of intervention or fidelity of implementation is key for psychotherapeutic intervention. The other third problem we have in the field is innovation and efficiency. So we have not made significant progress with regard to coming up with new, more efficient interventions. And that's something that we have to work very hard in the field. We've made progress in demonstrating the effectiveness of a lot of therapies, but we have not been innovative in improving the efficiency of the interventions.
So you mentioned access to care and quality of the interventions. I think access to care is a very hot topic today. Why is there a problem with access to care?
I think all along we've had a problem with access to care, but we became fully aware of it during the pandemic. The pandemic put at the forefront the uh, emotional disturbances that children and adults experience. And because the pandemic pushed more people over the edge, more people started seeking therapy for their children, and they realized that the access is not there. So it became more evident to us. So that's an important thing in the field right now. Is after the pandemic, we're all trying to address the issue of access to care. And why do we have an access to care problem? I think it's a simple thing. It's the supply and demand. The demand is much more than the supply. So we don't have as many therapists as we would like it to be. So in a way, one of the solution is to train more therapists. The other thing is the issue that we are challenging for us is that, as I mentioned, the efficiency of the treatment. An example that I give very often is about the treatment, the surgical treatment of appendicitis. 30 years ago, when someone has an acute appendicitis, they will be admitted, they will stay 4 or 5 days in the hospital, and they will be discharged. Right now, if you have an acute appendicitis, you could be out within 24 hours. That's something that we are not seeing in the field of mental health. If a child has an anxiety disorder, they would require, let's say, 15 sessions of psychotherapy. They used to require that 30 years ago. They still require that right now. So that's why we have to think about innovative approaches to make our treatment a little bit more efficient. And one key thing here in child psychiatry and child psychology is, and as I mentioned earlier, we work with a parent or with the parents. They could be an extension of us therapists in the implementation of the intervention. Fathers and mothers could learn skills, parenting skills that could help in the improvement of the mental health well-being of their children. The other thing in terms of that challenging with regard to access to care is monitoring the improvement over time. If someone comes to see a physician because they have pain, it's very easy. You can ask them, do you have pain or no pain? And that's going to determine whether you continue the treatment or not. Another example is fever. We can measure the temperature and we say, okay, the child has no fever, then we should start thinking about stopping the treatment. In mental health, we don't have as many tools as we would like it to be, and we don't implement them. Even if we have tools, we don't implement them as much to be able to monitor the improvement of the child. And we don't have the black and white that we see sometimes in fever, no fever. Like we talked earlier, the kid is a little bit better, but is that enough? And that's where is a little bit more challenging with regard to providing care to children and adolescents.
The technical term of what we're talking is measurement-based care. Yeah. And interestingly, I have a colleague who works on a platform using AI to implement measurement-based care. And clinicians do not even check the outcomes of what they are doing, right? This platform is called Ilios. It's a great resource for therapists. And even though we have the tools there, we don't do it. So we need to break some of our habits. It's like we're doing stuff, we don't measure whether it works or not, and here we are.
Yeah. We're guilty as professionals. Another Clear example. Every time you go see your pediatrician, they measure blood pressure, pulse, temperature, fever. We don't do that for patients we see weekly or even monthly. So we have to change these habits, and these instruments should be administered on a regular basis. Let's say not weekly, but at least monthly or every 3 months, and it should be automated. And now we have the tools with electronic health record to be able to do that. And we're guilty. We don't do that as we supposed to.
And I have the last two questions. One is more targeting parents. The other one is more targeting the providers, right? There's plenty of parents having a really hard time getting service for their children. What would you advise them?
We deal with on a daily basis, as I mentioned. So the best thing that the parents can do is educating themselves about what might be going on with their child, and also finding ways to learn parenting skills that will help with their children. Learning parenting skills can take different shapes and forms. The first one is they can read a book about that. Like if the kid has disruptive behavior, they can do that. Right now, there is innovative methods that are available out there, either apps or a program that we rely on artificial intelligence, where they can ask questions how to deal with behaviors, how to deal with tantrums, how to deal with sleep disturbances, and learn basic skills on how to manage these behaviors. Other things that parents can do is participate in group therapy, parent education group, where they will learn skills on how to deal with, non-compliance, impulsivity, temper outburst.
Thank you. And what would be your advice to the mental health providers or clinic providers on how to solve the problem of access?
Yeah, we have to be innovative. We have to think a little bit outside the box. We have to rely on technology, artificial intelligence, large language models, to integrate technology in our clinical practice. Uh, the hope is that if the treatment of anxiety will require 20 sessions or 15 sessions, the hope is that we can integrate some form of therapy that rely on, let's say, conversational agents to allow to shorten the duration of therapy from 15 to 10 or 8. That's going to increase capacity. That's going to facilitate access to care. And more importantly, it's going to standardize the delivery of the care, of the treatment, and will minimize a little bit the idiosyncratic approaches that some of us implement, or most of us implement in our psychotherapies.
Thank you so much, Antonio. I hope that people learn from these conversations. I think I got a lot of very useful insights. We'll ask everyone to subscribe to the channel or leave us questions in the comments, and we'll try to address them as quickly as we can. Thank you so much, Antonio.
Very good. Thank you, Eduardo. Thank you for this opportunity.